Welcome, everybody. I'm André, Deschamps, a prostate cancer patient. I was diagnosed being 51, which is 20 years ago, and I received prostatectomy. Today, I'm a survivor. I'm cancer-free, but one of my goals in life is to inform patients better about quality of life and the treatments and the options they have. I'm very glad to have today with me Professor Karen Fizassi from Russie in France. Karen, I just give you the word.
Thank you very much, André. So delighted to be with you today. So this is the disclaimer for patients today. And now those are my disclosures with participation to advisory boards and talks for various companies. And the money actually doesn't come to me, it goes to my institution. So we've selected, André and I, 4 presentations at the recent ESMO meeting in Madrid, in Spain, that we thought were of interest, or most interest for patients. There were actually many presentations interesting at the Congress. So we will present these talks to you, and we're going to go one by one and have some discussion, starting from localized disease and then moving to metastatic disease. So the first paper is actually a very large analysis that you will see from thousands of patients with apparently at least localized disease, to try to better understand who has a good cancer. I don't know whether a good cancer exists, but at least a cancer which is not at risk, and who has a bad cancer. And I know what a bad cancer is, and that's a cancer that can be lethal. So this was really the general idea. And for most men with high-risk localized disease, the standard of care is currently combination of radiation therapy and hormonal therapy, typically for 1.5 to 3 years, depending on the exact situation. So what you're seeing here is a large effort conducted by ICECAP. ICECAP is an organization, international organization, transatlantic, that decided some years ago to pull together data from many comparative trials or large trials, so that we will have enough data from thousands of patients to make sure that what we will say is actually true, if you will. So this is really the philosophy of the ICECAP effort. And for this particular analysis, they selected men who had localized disease, so non-metastatic disease, non-disseminated disease, and who were treated with radiotherapy and hormonal therapy because they had at least one characteristic, one parameter, indicating that this was not a good cancer. So this is about 3,604 men. So really a big set of patients. The slide shows the characteristics of these patients. And as you can see, most of them had a high PSA value when they were treated for their cancers. 57% of them had greater than 20 for their PSA. Probably even more important, more than 50% of them, and more than half of them, had a high Gleason score, and probably most of you are aware that the Gleason score is assessed at the microscope, and that's a way to assess whether cancer is biologically aggressive or not. A Gleason score of 8, 9, or 10 indicates an aggressive cancer. And again, this was the case in more than half of the patients. 72% of the patients had T3 or T4 disease. And this means that the cancer was outside the prostate, outside the capsula. So again, this is a sign that this is potentially aggressive. And finally, 12% of these men had evidence of lymph node contamination from the cancer at the CT scan or at the MRI in their pelvis. And again, this is a sign that the cancer can go somewhere else, of course. Okay, so we know for, say, 2 decades now that these parameters indicate that this particular gentleman, if he has it, is at risk or more at risk than other patients for relapsing with PSA increase or metastatic dissemination. What we didn't know very well is how best to combine these 3 or 4 different parameters together to identify truly who are the patients who probably need more treatment upfront to try to improve their outcomes. And this is exactly what ISCAP did in this presentation. As you can see, this complex, of course, table, you see the Gleason score and the PSA to the left-hand side. You see also the lymph node invasion. And you see, according to that, whether these patients are at risk of relapsing or not. And this is also another way to look at this combination. And you will see that basically patients who do worse are the one at the bottom right of this table, with basically at least 1/3 of them relapsing by 5 years' time, developing metastasis. And those are men with clinical evidence of lymph node invasion on the imaging and a high Gleason score, Gleason 8, 9, or 10, which of course is not a surprise, but this is clearly telling us that those are the patients with the worst prognosis when they have localized disease. On the other hand, some other patients, for example, those with T3 disease and a relatively low Gleason score of 7 and low PSA value of less than 10, so they have only T3 disease as the only sign of poor prognosis. Actually, these patients do pretty well. For most of them, 87% of them will not develop metastasis and will not die by 5 years' time. And of course, I'm not going to detail all the subgroups, but this is helpful to counsel a patient, and most importantly to us, also to design trials to try to invent new treatments to cure even more patients. So those curves are another way to show this data. You will see in red the curve of patients with just one adverse factor out of high Gleason score, T3 disease, high PSA, or nodal disease. So if you have only one criteria of these criteria, this is the risk of developing a metastasis or dying according to the time. And you will see, of course, that the more the time, the more the number of metastasis or death. But of course, some of the deaths are due to just life, not cancer. Now, in black, you will see the same evolution, but now for patients with 2 or 3 risk factors. And in blue, the evolution for patients with nodal disease. And again, this is clearly the highest risk factor. To the right-hand side, the same analysis, but this time for overall survival, counting on only death, not metastasis. Now, another way to look at this data is to look at time to metastasis. It's pretty much the same thing, but you're not counting death events. You just, especially those which are not due to cancer, you're counting only metastatic events. And to the right-hand side, this is prostate cancer specific mortality, which is actually counting only patients dying from their cancer. So those four curves or four figures are important again, because for the next to come trials, this will help us to identify who are patients who are the best candidate for new therapies to try to improve our outcomes. Of course, you don't want to select patients that we mostly cure with existing treatments, and we don't want to arm them with new therapies. But for patients who are not candidate for cure, of course, you want to do your best to improve their outcomes. And this is the conclusion, and we will be now able to discuss, André and I. So again, the study clarifies which patients with localized disease are at risk of relapse after primary local treatment, radiotherapy, or surgery. And this data is also of very most importance to advise patients, but also to design the new clinical trials. André, any question about this?
Yes, thanks for explaining to us this very important prognostic study. But as a patient, my question is, are you, based on the figures that you were just showing, advising me to, if I'm at the bedside, are you advising me to have another treatment before my relapse? Because today there is an extra treatment once you see the cancer coming back. But will this study be used to do something earlier?
Yeah, I mean, this is the exact question. I agree with you, André. So basically, let's say back in the 90s, these patients were treated with only one local treatment, either prostatectomy or radiation therapy. Approximately 20 years ago, we showed that two treatments are better than one. And this is why hormonal therapy was combined with radiotherapy. And different studies shows that these two treatments were better as compared to either treatments used alone, hormonal therapy or radiation therapy. And more recently, you're very right, a trial showed that adding a second hormonal therapy, so 3 treatments in total, for patients who are at a very high risk, so those, for example, who have typically 2 or 3 of these high-risk criteria, then 3 treatments does a better job as compared to 2. And this was achieved just 2 years ago, and it's more and more becoming a standard of care. So you see, these parameters and how we pull them together are really key to advise the patient whether they should go for just 1 treatment, 2 treatments, or 3 treatments. And perhaps in the future, we will be able to even fine-tune better all these things and maybe treat some of these patients with 4 treatment. I don't know, of course. So your question is absolutely crucial.
Yeah, I just have one last question here about this study. You show us figures of probability. Yeah. What is the threshold that we patients should use? Is it when we have 50% chance or when we have 80% chance?
I think there's no final answer to that. And this is kind of subjective, if you will. Usually in medicine, we tend to make a decision probably based on at least 3 or 4 different aspects. Number one is indeed a threshold, as you said, the one you like, of course, 40%, 50%, 80%, and of course, there is subjectivity. But this is one parameter. The second is how the treatment is going to be more efficacious if we use it. If you're moving from 40% to 60%, I think most of us will be keen to do that, patients and doctors. Now, if it's moving from 40% to 42%, maybe not. The third aspect is obviously toxicity, adverse events, and this can obviously counterbalance or not the efficacy. And the fourth aspect is comorbidities, life expectancy, and patient subjectivity, of course, because we are here to treat patients and to serve patients. As a doctor, my job is to explain as best as I can what treatment I think is appropriate and why is so. But at the end of the day, the patient is the boss. And if a patient says, no, thank you for X reason, I have to respect that, as far as I understand that it was properly explained all the different aspects. So I think all these aspects are very important for decision making. It's not just a threshold, it's everything. And it's a shared decision with the patient.
Okay, thanks for answering this question, Karen. I have no further questions on this study.
Thanks, André. So let's move to the second trial, and actually it will come back a little bit to your question. I'll come back to that in a minute. So this is a presentation about patients who are treated locally with surgery. And the question is whether they should receive radiotherapy either just after the surgery to try to prevent a relapse, or wait for the relapse to occur by PSA rise, but without clinical relapse, and then start the radiation therapy. And this has been an ongoing debate for about 2 decades, because of course you may think that you will be more efficacious if you're using radiation therapy just after the surgery, with maybe a lower burden of cancer. But on the other hand, many patients are cured with prostatectomy. You just told us that you are cured with prostatectomy. So if someone would have give you radiotherapy right after the surgery, probably you would have received this treatment for nothing, and potentially with the side effects. So this is why it was so important to compare these two philosophies, if you will. And in this trial, which is a large trial, patients were selected as having localized prostate cancer treated with surgery. Very importantly, their postoperative PSA value was undetectable, and they had to have at least one characteristic indicating that potentially they may relapse. For example, a PT3 disease indicates that the disease is just outside the prostate. Gleason 7, 8, 9, or 10. I explained that high Gleason means higher risk of relapse. An elevated preoperative PSA value and positive margins means that when the doctor who looked at the microscope the prostatectomy specimen, so the prostate, if you will, with the cancer, he or she found some cancer at the margin of what was removed by the surgeon, indicating that there might be some cancer at the other margin, which means in the patient. So these patients were randomized, which means that one of them received one treatment, the other one received another treatment, to receive either immediate radiation therapy, so all of them before a relapse occurred, while the other half received only salvage radiation therapy in case the PSA was rising after some months or some years during the follow-up. And the investigators, after that, look at progression-free survival, which measures how many patients eventually experience a relapse. So this trial, which is called Radicals, and it's an important trial with, I can't remember the exact number, you may or may not be able to read that, it's approximately 1,000 plus of patients. This was already analyzed 2 to 3 years ago, and published already. And there was actually no difference. But sometimes you don't really see immediate difference after 3, 4, 5 years in prostate cancer, and you need a longer follow-up to be able to show a meaningful difference. So this is why this longer-term analysis was important. So as you can see in this table, and again, I will not go into too many details, but most of these men had PT3 disease, meaning that they had cancer just outside the prostate, outside what we call the capsula, which is a bag, around the prostate. And 2/3 of them had positive margins, again, indicating that at the microscope, there was some cancer right at the margin of what was removed. Importantly also, only a minority of these patients had Gleason score of 8, 9, or 10, 17% or 16%. So most of these men had Gleason 7 cancers, which is important for the consequences of and the interpretation of the trial, and I'll come back to that. Basically, what this ESMO analysis shows is what was already published 2 to 3 years ago, showing that there was, number one, no difference between what we call adjuvant radiation therapy, which is immediate radiation therapy for all patients, versus selecting only patients for relapse to get salvage radiation therapy. If you look at the time it takes for the patients to develop metastasis, it's the same. And overall survival, which is basically measuring whether you're alive or dead, is exactly the same thing. I think the second very important message is that most of these men do well. And I think this is an excellent news. Even if you're selecting some men after surgery with some risk of relapse, you can see by 7, 8, 9 years after the surgery, most of them never develop metastasis, and most of them remain alive after their surgery, which of course is an excellent news for patients. So I think the conclusion for this particular trial is that for most patients treated with surgery and a post-operative undetectable PSA, and this is key, just no immediate radiotherapy is needed. And we can safely wait and see what's ongoing. If patients never develop a PSA relapse, they don't need any more treatment, just surveillance. And that's the case for the majority. Now, if a patient develops a PSA relapse, the salvage radiation therapy will be as efficacious as the same treatment used for all patients right after the surgery. So this is important. I will still mention one caveat though. This data applies for men with mostly Gleason 7 cancers, and this is of course the majority. But for patients with more aggressive cancers, 8, 9, 10, I think the jury is out at the moment, and we should be cautious. A more in-depth analysis of a trial is needed. There are also some other trials. We conducted another trial in France, and I know there is another one in Australia and New Zealand. So all these trials will be important to analyze in depth regarding patients with a highest risk of relapse to see whether for these particular patients, radiation therapy used immediately should be advised or not. And right now we don't know, but hopefully we will know soon. Okay, so André, any question regarding the second?
Yes, first, I have a remark. I think this is a very important study because quality of life for patients is very important, and we all know the negative effects of any therapy. So if we can do without a therapy, it's always much, much better for quality of life. So therefore, I think this is an important conclusion. My question is, what is a relapse? I mean, when should I, as a patient, be worried about something happening to me and agree together with my doctor to have a new treatment?
So the answer to your question is that in most cases, say 99% of cases, the parameter that can tell us there is a relapse is a rise in PSA. And after prostatectomy, the current definition of a relapse is a PSA greater than 0.2 nanogram per ml, of course confirmed in a different measure, just in case there is a lab mistake. We don't want to see that. So we always double check, of course. But if this is confirmed, it means that this is a relapse. Having said that, it doesn't mean this is a bad relapse. And actually, many patients who will experience a PSA relapse will never die from their cancer. And actually, some of them just don't need any additional treatment. There is some fine-tuning there. You need to see the pace of a PSA. The faster it goes, the worse. PSA with this kinetic are typically much more indicating an indolent prostate cancer. The Gleason score remains also very important. Authorities, Gleason 8, 9, or 10 are the bad players. And also the time it takes from the primary local treatment to the PSA failure, so the PSA rise to occur, is also a prognostic factor. We don't like immediate or rapid relapses, just a couple of months. This is usually indicating that something bad is ongoing. Now, if a patient has a relapse, a PSA relapse, after 2 years, 3 years, 4 years, 5 years, it's usually an indication that this is a mostly indolent cancer. So again, PSA relapse doesn't mean that it's a catastrophe. You need to look at these parameters to advise the patient as whether a new treatment is indicated, and if yes, which one.
Yeah. You have explained to us in the previous study the risk factors that we have. Would you advise, when all those risk factors are unfavorable, to do the treatments immediately?
Probably yes. Especially when there are several, poor risk factors. This is an indication that we should probably not wait. And I'm glad you're asking me the question, because in many cases of localized prostate cancer, you can really take your time and think twice about what is most appropriate. As you well know, André, in some localized disease, the Gleason 6 cancers, small cancers, we can just use what we call active surveillance, which is no treatment at all, and just look at the evolution of the cancer, which is mostly indolent, and most of these men will never need a localized treatment. So you can take your time. But you're very right. If a patient has poor risk factors, this is a good sign that you should not waste time and go for treatment, and mostly combined treatment in most cases.
Yeah. Last question on this item. If my PSA is not going down to 0.2, is that also a reason to treat?
The answer is probably yes, especially after prostatectomy, because the only organ that makes PSA is really the prostate. So if the prostate was properly removed, and if the PSA doesn't go down to lower than 0.2, it means that there's still some cancer somewhere. So in those cases, typically we use immediate salvage treatment, if you will. We discuss radiation therapy and systemic treatment, so hormonal treatment, either alone or together, depending on the situation. But in most of the cases, the answer to your question is yes. A treatment should be considered.
Okay, thanks.
My pleasure. So let's move to the third presentation that we selected. And we're now moving to men who have metastasis, so dissemination of their cancer. As you well know, André, most patients with metastasis from prostate cancer have bone disease and sometimes lymph node disease, and more rarely some other cancers. We are using hormonal therapy for these men, and one of the very important progresses in the last years has been intensification of hormonal therapy. We're using only what we call androgen deprivation, which is removing testosterone from the patients using drugs. And we were using that alone for decades. But, in the last decade, we could demonstrate that intensifying treatment with a second hormonal agents using pills does a much better job as compared to androgen deprivation alone. But of course, some patients with time will develop cancer progression, again with a PSA rise, and sometimes with symptoms, and sometimes with new lesions seen in the imaging. And the question is, what's next, of course, for these men? So this is why the PSMA-4 phase 3 trial was so important. We know already that lutetium PSMA, which is a radioligand, is an active treatment for men who have basically exhausted all existing treatments, hormonal therapies, but also chemotherapies. And this was shown 2 years ago in a phase 3 trial, which is called Vision. And this treatment is getting more and more adapted. For example, here in France, we are using it quite broadly in these patients who have failed many other treatments and clearly helps patients. The next question was really whether we should use that very same treatment, lutetium PSMA, earlier in the course of a disease. But before I show you the treatment, I probably need to explain what this treatment is. Most prostate cancers express a protein called PSMA, which is located at the surface of a protein. So what we do is that we inject in the blood of a patient a ligand that goes to cancer cells, binds to the protein, and because this ligand, this molecule, is associated with a radioisotope, the radioisotope will attack the DNA of the prostate cancer cells and hopefully will kill them. So this is the principle of this treatment. It's a kind of Troy horse, if you will, that we are using here. So the design of PSMA-4 is as follows. Patients had received androgen deprivation and what we call a second generation hormonal agent, abiraterone, enzalutamide, apalutamide, or darolutamide are drugs that we call second generation hormonal agents. And again, as I said before, these agents are very important. They clearly improve outcomes of patients, including overall survival by years. But these patients, unfortunately, had failed these agents, and their PSA was rising while they were now receiving them. So for some of these patients, the next step is typically chemotherapy. But for some others, the cancer progression is more indolent. And we don't necessarily want to use chemotherapy immediately. And for some others, either they don't want chemotherapy at all for personal reasons, as I said, this is always something we need to discuss with patients, or they are not fit enough to receive chemotherapy just because they have comorbidities or because they are very old, and it would be just too dangerous to use chemotherapy. So this is more for these patients that we invented this particular trial. Again, patients not immediate candidate for chemotherapy, and they were selected to either receive lutetium PSMA immediately or to receive a second or even a third, if you will, hormonal manipulation using another, what we call androgen receptor pathway inhibitor. So again, this family of agents, including abiraterone and enzalutamide, typically. And I'll speak about it later on, but there was also what we call a crossover. So patients in the control arm, in the control group, those who receive another hormonal treatment, if they developed further progression, they could actually receive lutetium PSMA as a delay strategy, if you will. So we were really comparing immediate lutetium PSMA versus delayed lutetium PSMA for these patients. So this is, as you see on the screen, a typical population of patients with metastatic disease who were resistant to classical hormonal therapy. 87% of them had bone metastasis. As I said before, their PSA was approximately 15. Abiraterone was previously used in approximately half of the patients, and enzalutamide was used in approximately 40% of the patients. Only a minority of these patients had liver metastasis, and this is because these patients are typically selected for chemotherapy, so they were outside this trial, if you will. So this is showing you the primary endpoint of the trial, so the primary measure, which was progression-free survival as measured by imaging. So we were looking at how many patients will develop new metastases. And as you can see, it's much better when lutetium PSMA is used immediately, the blue curve, with a median time to progression of approximately a year, as compared to approximately 6 months or even less in the control group receiving another hormonal therapy. So this corresponds to approximately a 60% reduction in the risk of progression or death. This is a complex analysis that we like to use in general to look at different subgroups. And sometimes we see that some patients benefit more from the new treatment as opposed to some other groups. But here, honestly, it seems to be that most subgroup of patients benefit from lutetium PSMA as opposed to the hormonal treatment. We looked at other efficacy parameters. For example, this is what we call response rate. So if you can measure on the CT scan a lymph node, which is just too big, how many of these patients will have a shrinkage in their lesions? And as you can see, this is much more frequent with lutetium PSMA, approximately half of the patients, as compared to approximately 15% only with hormonal therapy. Also, how many patients had a significant decrease in their PSA, more than 50% decrease? This was achieved in 57% of the cases with lutetium PSMA, as opposed to only 20% with hormonal therapy. So clearly much better. We looked at overall survival, which is what we call an interim analysis, or if you will, an intermediate analysis. This is not mature. Most of these patients, fortunately, are alive. And we see a 20% reduction in the risk of death. But again, a longer follow-up will be needed. Very importantly, 85% of the patients in the control group had subsequent access to lutetium PSMA, which is good because this is really what we wanted in this trial, comparing immediate treatment versus deferred treatment. In terms of safety, generally speaking, lutetium PSMA is well tolerated, but having said that, some patients actually have some side effects, including dry mouth, usually not that bad. It's not typically not long lasting. My French patients are typically telling me that they can still swallow and enjoy all a good wine, which is very important in our country, as you probably know. We also see sometimes what we call bone marrow insufficiency, which means that bone metastases are probably just too much irradiated by the treatment, so that the white cells or the red cells are below the normal value. But this was not observed very frequently, to be honest, in this trial. As you can see, and probably very importantly to me, and I'm sure to you, time to deterioration of quality of life was significantly improved in this trial with a 40% reduction in the risk. And this was measured by patients themselves, not by doctors. And also time to deterioration in pain was also significantly improved with a 40% reduction also, or 30% reduction, sorry. And also what we call time to skeletal-related events, including fracture, major pain requiring opioids or radiation therapy. And this was significantly improved by the lutetium PSMA. So overall quality of life is improved, if you will, with this treatment. So what does it mean for everyday treatment? I think this important trial establishes lutetium PSMA as a new important option for these men with cancer progression after hormonal therapy, and actually a second generation hormonal therapy. And I mentioned here on the slide the name of the drug so that everybody can understand what I'm speaking about. It's not the only one. We have, as I said before, chemotherapy with docetaxel, which is also a very important treatment for these men. We also have, for a subgroup of patients, what we call the PARP inhibitors, and this is for patients with very specific molecular alterations that we measure in the cancer tissue or even in the blood. So more and more we have different options for these men, which is excellent. And this is an excellent news for patients because it means that we have a new option for many of these patients in this situation. André, thank you for listening, and I'm very happy to answer your question if I can.
Thanks again. And you must know that lutetium, we receive a lot of questions in our patient community about this option. And therefore, my first question is, can you give an idea how many % of the patients can have this and show expression?
It's actually the large majority, approximately 90%, so 9 out of 10, actually have PSMA expression, and very often strong PSMA expression. A few patients have both PSMA positive cancer and PSMA negative cancer. So right now, for these men, we tend not to treat them because, at least with lutetium PSMA alone, because we understand that the treatment will not target the PSMA negative cancer. So we don't want it to grow. We prefer going for other treatments. But it's really showing you that the vast majority of patients actually could be candidate for PSMA lutetium in this particular setting.
Okay. Another question often asked to us is, we all know that the adverse effects, as you explained to us, of lutetium are relatively low. Yeah. Now, with abiraterone and all the other drugs, that's not the case. Why can we not have lutetium earlier?
Well, this is actually what we are currently testing. But we need to be cautious, of course. It's true that right now, with the current experience, lutetium PSMA is mostly well tolerated. The side effects, as I said, include dry mouth, but usually mild and not long-lasting, typically a couple of days, with some exceptions. What we call hematological toxicity, white cells, platelets, red cells. So we need to be cautious with that, but usually it's mild also. And some nausea of the meeting, but this honestly can be prevented. We have drugs which work very clearly, and all our patients should actually not experience nausea. We should use these drugs prophylactically. So in upfront, if you will, before the patient develops nausea. So it's true that usually this treatment is well tolerated. But I'm glad you're asking me the question, André, because with any radioisotope, you need to be cautious. Because if you're using a treatment in a man who has typically 1, 2, 3, 4 years to survive, this profile, the safety profile is very acceptable. You're typically not harming patients. But if you're using the same treatment in patients who will survive much longer, or actually who will live much longer, say a decade or even 2 decades, who knows whether that radioligand treatment will not induce leukemias or what we call myelodysplasia, which is, if you will, a cancer of the blood cells, which is induced by the treatment. And of course, we know it can happen with some irradiations. So we need to be cautious with that. And this is why we decided to start the very first trial called Vision, published 2 years ago, in patients who basically had nothing to lose. They had exhausted everything. And this was a victory, or at least a partial victory, if you will. It works. So this is why it's becoming a standard treatment for these men. So it's helping them. What you just saw, and what was just presented at ESMO 1 week ago, shows that the same treatment can be used earlier in patients with cancer resistant to hormonal therapy, but who have not seen a chemotherapy for what we call castration resistance. And we're now testing the same treatment even earlier in the course of the disease, but we're very cautious. We are explaining all what I'm explaining you to the patients, and we're making the decision together to have them participating or not in the trials, testing the same treatment in earlier setting of the disease. And in the coming years, we will see whether this is appropriate or not. So we need to be very cautious about these things and treat patients only in the context of a trial. So at least we know what we're doing, which is very important.
Okay, and then my last question in this regard is, for those patients who are not PSMA sensitive, do you have all biomarkers in your skill box that could help them?
We do. We have, for example, what we call BRCA testing. BRCA is an important gene, BRCA1 and BRCA2. And in approximately, say, 7-10%, we see alterations of these genes. And this could be a very good reason to treat the patients with what we call a PARP inhibitor, or with a very specific chemotherapy from a platinum family. And typically it works. In another subgroup of patients, what we call MSI high is present. This is approximately 3% of the total. And then immunotherapy is probably very appropriate. It's a very small subgroup of patients, but then immunotherapy is very likely to work. We also have subgroup with various alterations of what we call the androgen receptor. For example, mutations are present in approximately 20 to 25% of these men. And we are right now testing a third generation of androgen receptor inhibitors that seem to be very active in these men with mutations. And actually, there are more, P10 loss, more alterations, CDK12, that can actually help us to decide for this particular treatment or this treatment. So we are going more and more towards to precision medicine in advanced prostate cancer.
Thanks.
My pleasure. I see that time is flying, and probably we should move to the fourth paper. And actually, this is going to address part of your last question because it's a new target for men with prostate cancer. This is a protein which we call STIP1. And we have a new drug that targets that. So let me maybe explain that with my hands. It's going to be easier probably. So STIP1 is a protein which is expressed at the surface of many prostate cancer. We know that for a long time, but until recently, we didn't know what to do with that. And for the first time, actually at ESMO a week ago, we saw the first data from a drug, which is, if you will, a smart immunotherapy treatment targeting STIP1. So let's imagine that I am the drug, I am the antibody. And actually, I have two arms. One arm is going to bind to the protein, which is located at the surface of prostate cancer. It's called STIP1 as protein. And my other arm is going to bind to a white cell, so an immune cells, if you will, and this end will take the cell and take it next to the prostate cancer cell so that it will attack the prostate cancer cells. So this is really the philosophy of these bispecific antibody. And there are other bispecifics with other targets. So this is the very first trial testing this particular bispecific antibody. I'm not going to go into too much detail, this is complex, but just to make it easy, the idea is to use this antibody in patients who have terrible cancers and they have already exhausted many existing treatments, if not all. So we are just looking for new treatments for these men. So we're starting at very low dose for these patients to make sure we're not harming them. And then if this is safe, we are progressively increasing the dose in the same patients, but also in other patients. Okay, this is the principle of a phase 1 trial. So as you can see, 97 patients were included. So it's quite a robust number of patients. They had received at least, or in median, 4 previous systemic treatments, hormonal therapies, chemotherapies. Some of them had received radioligand, PSMA, what I just explained, or some other treatments. Visceral metastases were present in half of them, liver metastases almost 40%. So really, you see really bad cancers, okay, poor men. And as you can see, this treatment appears to be very effective. So it's a great news for us and for patients, most importantly. This figure is showing how we assess treatment efficacy. Any bar going down shows that the treatment is efficacious. And of course, the lower the bar, the better. If it goes to minus 100%, it's a good sign. It means that there's no more detectable cancer. On the other hand, the few men with a bar going up, unfortunately, did not benefit from this treatment. And as you can see, it's a minority here to the left-hand side. But all these men actually derived some benefit. And those shown in yellow are the ones who receive the highest doses, and they seem to benefit more from the treatment as compared to that with the blue bars, who were patients at the very beginning of the trial who received low doses. So those appears to be important. Another way to show efficacy is to look at imaging. If you look at the left-hand side, this is a CT scan. All these dark round things are liver metastases, here, there, here, etc. And you see after 24 weeks that there remains only this one and this one, probably maybe one here, nothing else. This is shrinking dramatically. To the right-hand side now, you can see a PSMA PET. All what is dark shows cancer, except the kidney, which are normally dark, and the salivary glands here, which are also normally dark. But all the rest is cancer, and big cancer. And after 12 weeks, you see that it remains only perhaps here, maybe there, remaining spots and some tiny ones here, but nothing big as compared to what was evidenced at the beginning. Obviously, this comes with a cost to the patient in terms of safety. And of course, every time you're trying to manipulate the immune system, you need to be cautious. With this treatment, bispecifics, we see what we call cytokine release syndrome. And I'm sorry if it's a complex name, but you can just translate that in normal language by a flu, a big flu. You can imagine that a patient has fever, they feel tired, they have to rest in bed, and sometimes you have to have an intensive care unit just next door to help them. So it's not nothing. But the investigators were mostly able to fine-tune how to best use the treatment to reduce this amount of adverse events. It's clearly not perfect, but they're clearly making progresses, and hopefully this will continue, and we will find ways to keep the efficacy and to mostly get rid of most of the side effects. So this is plus or minus where we are with this treatment. Again, it's brand new, first time this is being shown, and it means two things. Number one, we have a new target for treatment, STEAP1, and number two, we can target this with this treatment, but perhaps in the future, we will also have other treatments, bispecifics, but also what we call ADCs, or maybe radioligands, that can also target this particular protein. So it's really opening a new field, which is very important. André, happy to answer your question if any.
Yeah, thank you. First of all, I'm very glad that you've measured adverse effects for the patients, because that's not happening in a lot of studies. Is my conclusion correct that there was no relation of adverse effects towards the dose?
That's true. That's true. The higher the dose, the higher the side effects, typically, of course. Also, the duration of infusion can have an impact. And this is something we're trying to work on. Also, for example, if you just give a low dose, the patient then might be able to tolerate a higher dose, say a couple of days after that. So you can progressively increase the dose to make the treatment much more tolerable. So those are exactly the different strategies the investigators are currently testing to try to identify what is the best way to give this treatment.
Okay. Then my last question is, you now have data, you have defined what the dose is doing. Yeah. Can you now tell us what the height of the dose should be for the next study? I mean, do you have in your own mind an idea now after this study, this is the best thing, this is worth a further study?
I think, the decision is not made regarding what is the ideal dose and schedule. Again, even if you saw that almost 100 men have been already treated, they are still trying to fine-tune that, and they are currently expanding 2 different doses, which appears to be active and mostly well tolerated, to try to identify which one might be the best one for further development. So I think we will probably have an answer to your question maybe in 6 or 12 months from now. But this is very key, because it's probably better to take your time to really fine-tune this and identify the best schedule, because then you will treat thousands of men. And if you didn't pick up the right one, then it's really a pity. And it actually happened in the past, where that we didn't identify the best dose, and it was just a little too high, efficacious, but a little too high, and then you're harming many men for nothing. So it's probably safer to take our time. 6 months is not that bad before you do the large development.
Okay, well, thanks for presenting to us those 4 studies, and I hope that your further work will help us to make our life better.
Thank you, André. Yes, no, it's true. It was an excellent ESMO Congress with lots of good news for the patients with prostate cancer. And by the way, also for those with bladder cancer or kidney cancer. So that's great for patients. And not speaking about other cancers, because it was an excellent Congress. And it really shows that we're making important progresses right now for the patients. So I'm really excited about that. Thank you so much, and I'm very happy to keep the conversation for another Congress. Thank you.
Thank you.